But I like the part about the swords, give them swords, a little raccoon and eye patches. Alright, okay. So, let's see. Screening test for newly diagnosed diabetes. Now we're going all the way back to proteinuria and hematuria, right? Huh? What do you think? What do you think? Huh? Not dipstick, that's right. Why not a dipstick for a diabetic? Because you're waiting until they're already spilling too much albumin. That's great, that's exactly right. That's not a good screening test for a diabetic. You're missing the opportunity to intervene way earlier. Okay, so what else? The electrophoresis, no. The urine protein electrophoresis would be something if you suspect multiple myeloma or something like that. If you suspect like a Benz-Jones proteinuria or something else besides albumin, it's not a good screening test. It's a very specific specialty test. Huh? No, the 24-hour isn't great as a screening test because people don't like to carry around buckets of urine. So keep going. B, UAC, urine albumin creatinine ratio. It's a spot test. It is the microalbuminuria test. Urine protein to creatinine ratio would be the A. That would be if you have somebody who has established proteinuria of whatever cause, not just related to albumin, and then you can monitor their seroproteinuria. But for our purposes, all intents and purposes, the UACR is a good screening test for pretty much anybody, even somebody who we're working up for an unexplained albuminuria, like a dipstick positive urine albuminuria. Okay? So diabetic screening, UACR, urinary albumin to creatinine ratio. And I know it was a long time ago, and I know that the acronyms just get all spilled up in your head, but that's why we're doing this little review to try to polish that off. What do they call CrossFit? What's another nerd term for CrossFit?
Functional fitness.
Right? So that's how I remember this one, okay? Functional fitness, in case you have to like lift hay bales over your head and then drop. You know what I mean? So, functional fitness. Okay? Orthostatic, that has to do with kids. That is literally has to do with when they're upright, they lose protein. When they are supine, they don't. So we do two different samples. Glomerular is what we've been talking about here in nephrotic and nephritic syndrome. Tubular is what we're going to talk about next in chronic kidney disease, really. And then overload is back to Benz-Jones proteinuria, something like multiple myeloma. Okay, so strenuous exercise, something that we would come in often find incidentally when somebody comes in for sick call after PT would be functional proteinuria. But what does that mean? Does that mean we're just going to assume it's functional proteinuria and write it off as such? No, exactly. Good, and that is a big takeaway from proteinuria and hematuria. What's the answer, do you think? All we have here is a dipstick positive hematuria. What did I say we need to have? Other stuff, right? Because dipstick positive hematuria could be what? Lots of stuff that involves heme or myoglobin or lots of other things. We want to confirm if there are cells. How do we do that? With a microscope. Exactly. Okay? Does that make sense? Now, let's say this question says we already confirmed it with microscopy. What would then probably the next step be to work up hematuria? CT urogram, that's right. All right, so that would be to confirm or to evaluate unexplained persistent hematuria. Does everybody remember that? Okay. Huh? Say it. Hypoperfusion, that's right. Hyperperfusion. And everything else is either in the kidney or after it, right? Pre-renal, before the kidney, hypoperfusion. Okay? I know I didn't give you the normal values, but what do you think? I always told you like which way the alligator's going. Greater than, less than, high, low, right? Which one? C. C. Factual excretion of sodium above 2%, that is abnormal, especially if the patient has a hypovolemic state, right? Remember the patient who has prolonged hypovolemia, now they're in intrinsic renal disease, they have acute tubular necrosis. We are spilling sodium inappropriately in dilute urine, also inappropriately, right? Because we should be saving sodium, saving water, we're not saving either, okay? V/N creatinine ratio in intrinsic renal disease, which way would it be going? Down. Down. That's right. Increased BUN is the same, so D and E are literally the same answer. Okay, and of course we would not expect a bland or unremarkable urinary sediment. What kind of things would we expect in a urinary sediment? Potentially for the intrinsic renal disease we've discussed. Cast of some type gives us cast cells, right, of some type. Talk about tubular cells, cast. Eosinophil cast with acute interstitial nephritis, right? Talked about blood cell cast with glomerular nephritis. Talked about fatty cast with nephrotic syndrome, okay? So we would expect stuff to be in there. I just told you this answer, except I used a different word. Huh? E, echo? Acute interstitial nephritis, that's right. And what kind of leukocytes? Specifically, eosinophils. Allergy-mediated process, right? That's the one, that's an intrinsic renal disease, much less serious than ATN, usually caused by drugs or some other exogenous nephrotoxin. Patient shows up with a rash, arthralgias, dark urine, and evidence of renal disease, intrinsic renal disease type labs, right? Wonderful. Any questions about that stuff? Okay. All right. Any questions about anything? We're all focused on emails. I understand. I get it. All right. So we will continue our discussion on nephrotic syndrome, finish up this lecture, go through tubulointerstitial disease really quickly because it's only like 21 slides. Like we're getting, the next few slide decks are, like I said, just sort of a mixture of topics that are still chronic kidney diseases, because what we're working towards is chronic kidney disease. Like the culminating lecture is after all of this stuff has its effect, what happens to a patient who has chronic kidney disease, and that's Friday. And so today we're going to do this one, the next one, and then I think renal vascular disease because it's really quick. Or whatever, tomorrow we'll be done early, and then hopefully we just have one left to do chronic kidney disease on Friday. And then my plan is to do a review for y'all after Hem-Onc at lunchtime that day. Obviously, voluntary, I will not make anything during your lunchtime mandatory, but I think at that point you'll all be focused on GU. You know, Hem-Onc will be off the shelf, E-Med will be off the shelf, and then we can really talk and do a good discussion for a review. Is that fair enough? All right. So, membranous nephropathy, which, adults. What was the one for kids from yesterday? Minimal change disease. That's right, minimal change disease. The most common primary nephrotic syndrome in children, minimal change disease. Now, adults, membranous nephropathy. So if you see a patient, an adult patient, who has a primary nephrotic syndrome, it's almost certainly membranous nephropathy. Now, of course, does that mean adults can't get the other one and kids can't get this one? No, because nothing is that certain. But just in general, 90% answer, and literally the 90% answer is what I've said. So, this is actually important because this is newish. I will say newish, okay? So phospholipase A2 receptor antibodies, PLR-A2, okay? PLAR2, excuse me. This is diagnostic of membranous nephropathy in adults. So if you have an adult with a nephrotic syndrome in the past, before we had this nailed down, patients almost always got a renal biopsy. Okay? And again, if you're punching holes in sick kidneys, it's not great if you don't have to. What this does is, if it's positive, then we don't have to get that patient to biopsy. Does that make sense? So this lab test tells us that this is in fact this disease, and we don't have to go and see it on an electron microscope. So it saves the patient that invasive procedure. So it's important. And it sounds like a pretty esoteric lab, and it is because it's just for this, but it also is pretty important to know clinically, okay? Second, let me go back to this. Truthfully, here, what I should put, the most common cause of secondary membranous nephropathy is diabetes. All right? So you might actually see diabetes present as membranous nephropathy, but then again, that's not a primary disorder, so what would this patient also have? Diabetic history, exactly, right? Diabetic history. Clinical manifestations, can we go through this already? But we know what it looks like. What is this guy or gal going to look like? Swollen, right? With foamy urine most likely because there's a ton of albumin in it. All right? Renal vein thrombosis, in this case, you guys remember the level where the real risk for renal vein thrombosis comes, or thrombosis in general? Serum albumin below what? Anybody? 2. That's right. Serum albumin below 2, okay? For some reason, renal vein, like you guys have already talked about the bleeding dyscrasias and the hypercoagulability states in HEMONC, right? So where do, like in a normal patient, normal Virchow's triad, where do clots form? Legs, right? Dependent areas, right? Clots don't just form in the cerebral veins or the mesenteric veins or the renal vein. That's weird, right? So they're usually some sort of secondary cause, either an inherited hypercoagulable state, or in this case, this patient is grossly hypoalbuminemic, and so they're at risk. And for some reason, this kidney disease likes to form thrombosis in the kidney vein, okay? So just remember the association, because it is a big risk, especially for those patients who go below that level, that threshold, all right? And labs, what's different here? That one, right? Everything else is the same, okay? So what does that mean? When I say nephrotic syndrome labs, 4 plus proteinuria, right? Low serum albumin, high triglycerides. What about BUN and creatinine? Both elevated. What about GFR? Reduced, right? Everything that we've already talked about. All right? All the same labs, okay? And again, this is the big reason why I'm just going to stop and say these antibodies. Why these antibodies are important, because again, if you don't have to take a piece of this kidney, all the better, all right? If you do, most of these nephrotic syndromes affect, well, you know, in minimal changes, there was effacement of the podocyte foot process we talked about. In this one, it's an alteration of glomerular permeability in the basement membrane. Okay. So enough about that. Treatment, again, what is treatment? What did I say? What was the treatment? ACE or ARB, yeah. ACE or ARB, and less commonly steroids in this one. You know, MCD, steroids for sure, plus minus ACE ARB. This one, ACE ARB plus minus steroids, so inverse. Does that make sense?